Good evening, all the aspirants. Here we have the speaker, Dr. Varun Pushkarna, who is Senior Consultant in Internal Medicine at Fortis Escortis Hospital, Amritsar. Sir, you may take over. Thank you.
So, good evening, aspirants. Basically, this is for the preparation of EDIC exam. So, EDIC is European Diploma in Critical Care, and I think you all are very well versed with the abbreviation. But the thing is that whenever we are preparing for an exam, it is the concept and the protocol with which we have to work. So, theoretically, you have to be very, very clear in your mind. I mean, strong or not strong, that is a secondary thing. But you have to be very clear as to what protocols you have to follow. So if somebody is admitted in a cardiac critical care, you know that these patients could be having any of the 4 or 5 conditions like acute coronary syndrome, like myocarditis, acute myocarditis, like pericardial tamponade, uh, cardiogenic shock. Usually not cardiogenic shock, but refractory cardiogenic shock. So what all you need to keep in mind as the algorithm in your mind of the management of cardiogenic shock, moving from cardiogenic shock to severe cardiogenic shock, then refractory cardiogenic shock, and then super refractory cardiogenic shock. So these are the stages that you will need to follow. Same way in neurocritical care also. So meningitis, meningoencephalitis, altered mental status, acute stroke, acute hemorrhagic stroke, and then traumatic brain injury. So you have to understand that as an intensivist, you are more concerned with the critical care part of the patient's management. Uh, that is why when we are studying the disease as a process, we usually get lost into the intricacies of the management. We should not be concerned, although it's good to know how to manage these patients. But the crux of the matter is that this is an intensive care exam. So you need to be very, very well versed with the micro graphics of the critical care part of the neuro thing. Like, for example, status epilepticus. When is the point when a critical care guy pitches in? If you have that amount of idea, then you will have the amount of idea how you will progress in the management of it, how you can help the patient achieve the whatever end result you want to achieve. So we will just go through the questions as to whatever possibilities of the examination are concerned. So we have a 62-year-old man with anterior STEMI. You don't need to know the definition of STEMI. That STEMI is two minimum 2 mm square, 2 mm or two small square elevation of the ST. You don't need to know that. You need to know that if the patient has STEMI, what is the management and how does an intensivist play its part. So a 62-year-old man with anterior STEMI is admitted to the ICU post primary PCI. So definitely they've taken away everything. The patient was admitted in the emergency, came with anterior wall STEMI, was taken up by the cardiologist, so no door to balloon time for you. The patient was taken up in the cath lab. The patient was taken up for the primary PCI. Intervention has been done. Now the patient, when he is under your jurisdiction, after arrival, this patient complains of persistent chest pain. His ECG shows new hyperacute T waves. What is the most likely cause? Anyone?
Pericarditis.
Stent
So,
thrombosis.
so usually pericarditis will set in after 3 to 5 days of uh, primary PCI or acute MI.
Then
As an
stent thrombosis.
intensivist, yes, as an intensivist, you need to know that the patient was taken up for primary PCI. Maybe there was a high thrombus load. Maybe the patient was not preloaded with 180 milligrams of ticagrelor or 300 milligrams of clopidogrel. God knows. This is a case scenario, a situation to trigger your mind to think. Like you thought this could be pericarditis, it's okay. It is good to think that it could be pericarditis, but wrestlers or pericarditis usually sets in after 36 hours. This is something which is life threatening. The patient has developed hyperacute T waves. In pericarditis, if it was the case, it would have been a global ST elevation. Global means not only in the interior lead, but in the posterior leads, in the lateral wall leads, in the limb leads, everywhere there should be and there should be a variable PR interval also, so that you should know that what will be the presentation in the ECG. If the patient has, definitely it will be a differential in the post PCI chest pain. But if the patient has hyperacute T waves and the patient is just returned from the cath lab, then the only possibility here is a stent thrombosis. So our onus should be to get the diagnosis immediately made, that if this patient has a stent thrombosis, then we have to do what? What do we need to do? Then we need to shift the patient immediately to cath lab, back to cath lab, and do a thrombosuction, and relieve the patient of the problem. Okay, very well. Now, if I have to just look into these things, the other ones, coronary artery spasm, theoretically it can cause that. It can cause that, but this is a transient thing. This is transient thing. It is a persistent chest pain. It is going on and on and on and on and on. As far as reperfusion arrhythmia is concerned, there is no mention of arrhythmia in the question stem. So you should not look at recurrent arrhythmia right now. You should just keep it aside. The patient has chest pain. So the chest pain in such a scenario, you have to see that if it is a naive or a native chest pain or a post-procedural chest pain. So if it is a native chest pain, means the patient came with the chief complaint, then it could be acute MI, STEMI, non-STEMI, or acute coronary dissection, or even acute pericarditis, acute myocarditis. All of them can be differentials. But right now, here it is already mentioned that this patient was taken up for a primary PCI. And after PCI, the chest pain reasons can be coronary dissection. There could be cardiac rupture. I'm thinking of the worst possible scenario. Stent thrombosis. Okay. Or a new MI in some other vessel in which the intervention was not done. That is also a possibility. Or a coexisting aortic dissection which got worsened because of, if it was a aortic dissection to begin, then if you do a procedure on such a patient who may have a coronary also, then what will happen? Any idea? If a patient has concomitant aortic dissection also, and you do a primary PCI on such a patient, thinking that this patient has anterior wall MI, you do an angiogram and you find that there is a 90% occlusion or a thrombosis sitting in the LAD, you open it up and then the patient develops chest pain, you missed that aortic dissection early on, what will happen? Any idea? What will happen to the aorta? Any idea? So aortic dissection will worsen. Why? Because you have given antiplatelets. Not only that, you have given anticoagulants also. So while you're doing procedure, you always give heparin. So what will happen is the dissection will increase. And the dissection will increase and it will be considered as a blunder that a patient who was taken up for PCI also had a missed aortic dissection and the patient would eventually lose their life. वो बचेगा नहीं. Second question, a 75-year-old, sorry, 75-year-old woman in ICU after an inferior STEMI suddenly develops profound hypotension with jugular venous distension and clear lungs. ECG shows ST elevation in lead 2, 3 AVF. What is the next best step? IV fluids, IV nitrates, diuretics, or immediate coronary angiography. So let us first make the diagnosis. Only then we will decide what the treatment or the next best step is. So this patient had inferior STEMI. So inferior wall STEMI has hypotension plus JV distance, jugular venous pressure is increased, plus ECG shows ST elevation suggestive of inferior wall MI. So can anybody tell me what is wrong here?
RV infarction is also there.
Very good. So this patient has RV infarction. So
we have to give IV fluids.
Yes. So everything fits into the setting of a right ventricular infarction. So when RV infarction has occurred, although you have put in a stent, because of the poor and lesser muscle in the right ventricle, if it has an MI there, it takes a little longer than the left ventricle to pick up his work. So what will happen is, because of the deficient working of right ventricle, there will be elevated RV pressures. Elevated RV pressures will lead to elevated RA pressure. Elevated RA pressure will lead to increased JVP. And because the RV is not pumping enough blood into the lungs and then into the left ventricle, there will be cardiogenic shock. So what kind of a cardiogenic shock is this?
Right sided.
Yes. So this is a cardiogenic shock of left ventricle, but it is secondary to reduced preload. What is happening is the stroke volume is low. We know cardiac output is stroke volume into heart rate. So what has happened here is the stroke volume has drastically decreased because RV is unable to pump blood into the left ventricle. So the LV filling has decreased, leading to hypotension. How can you improve the situation? By giving IV fluids. So by giving IV fluids and keeping CVP target around 18 to 20. So this is where you should need to keep your CVP for the patient. What will happen is this will lead to increase in
preload.
So preload will increase, and this will lead to increased filling pressures of the left ventricle, and then the patient will improve. You will keep giving IV fluids and keep their CVP high until the patient settles and until the RV function improves, that you can see on echocardiography or even on the ECG when the ST starts to settle. So this patient had an acute inferior wall STEMI leading to RV infarction, and post RV infarction, this patient developed a cardiogenic shock secondary to RV infarction. And the guidelines, recommendation, and physiology also favors that you give fluid to this patient, keep the CVP high, so that the these pressures are increased, and hence the filling pressures in the LV are also increased, and cardiogenic shock resolves. Immediate another coronary angiography will not help. Diuretics are a big no. They are contraindication in such a situation. So are IV nitrates. Sorry. Why are IV nitrates contraindicated in such a situation? Give me two reasons.
Vasodilation, decreased preload and afterload, vasodilatory effect. So more hypotension will be there.
Yes. So the first contraindication is the patient is already in hypotension. So in hypotension, we will not give IV nitrates. Second, it will worsen the hypotension. Even if by mistake somebody has given it, as a consequence, the preload will decrease, and as a decrease in preload, the situation will worsen even further. Very good. So there is this patient who post-STEMI develops cardiogenic shock in the ICU, and the BP is 85/50, and the patient is right now on norepinephrine. So we have a patient of STEMI. Now the patient has cardiogenic shock. When do we call it shock? Anyone? Why hypotension is not mentioned here? Why it is shock? Define shock.
As because ejection fraction is also reduced.
So basically, no. The basically hypotension plus features of hypoperfusion. So although they have not mentioned that there are features of hypoperfusion, they have just given you a diagnosis. So as an intensivist, you should be very clear with the terminology. Like you see in the earlier situation, it is said that the patient developed hypotension, this hypotension. But here it is mentioned that the patient has cardiogenic shock. So when we say cardiogenic shock, when the patient has features of hypoperfusion, the easiest way to check hypoperfusion is to check serum lactates. So what we test is serum lactates. And the earliest organ to assess for shock related hypoperfusion is kidneys. So the patient will have decreased urine output. So when they mention that the patient has cardiogenic shock, that means it should be clear to you that the patient not only has hypotension, but also has hypotension related hypoperfusion. So the BP is low and you have to act really fast in such a situation, or else the patient will deteriorate. So the blood pressure is 85/50 and the patient is already on norepinephrine. Echocardiography shows severely reduced LV ejection fraction, that is 25%, and increased SVR. So what will you do in such a situation?
Add dobutamine.
Yeah. So you will like to add a inotrope. You would like to increase the contraction. Better is to use something which is an inodilator. What is an inodilator? Inodilator is something that increases the contractility and decreases SVR.
Dilates the
Arterial
artery.
system.
Yeah.
Yes. So decreases the systemic vascular resistance. So right now in such a patient, the blood pressure is 85/50. The patient is on norepinephrine. If I were to answer it completely, I would say that I need to have this patient on number one, increased hemodynamic monitoring. I need this patient to have an arterial line to monitor arterial BP. Second, I need a CVP monitoring in such a patient. The patient is already on norepinephrine. The moment I add dobutamine to this patient, what can occur? What can happen? Norepinephrine is given because of hypotension. When you add norepinephrine, it increases the SVR to keep the blood pressure up. Now, if you add dobutamine, it is an inodilator. No matter how much inotropy it increases, but it also dilates the blood vessels. So it will be acting in opposition to norepinephrine. What can happen? The patient can have a hypotension further. And do you think this patient should be on non-invasive blood pressure monitoring?
Yes.
Oh.
No. So
No.
this patient cannot be on non-invasive because the non-invasive will tell you blood pressure after 10 minutes or 5 minutes of reading. And in the meanwhile, the patient can have a worsening of shock. So before adding dobutamine, as an intensivist, you should put a arterial line to this patient, monitor the arterial BP. Once you have arterial BP in hand, you add dobutamine at minimal possible dose. For example, adding 250 ml and starting at 2.5 rate. So once you start the infusion, you monitor the patient for any change in the blood pressure. if the patient has decrease in BP, you should increase the norepinephrine. Why? Because dobutamine is doing dual job here, inotropy and dilating the blood vessels. The dilatation of the blood vessels can be countered by norepinephrine, but the inotropy is helpful. So we would like to continue with dobutamine and increase the norepinephrine to maintain the SVR and dobutamine to maintain the cardiac output. Also, dobutamine will help in increasing a heart rate a little bit, so cardiac output will overall increase. Is that clear?
Yeah.
Yes.
Yeah. So we will not increase norepinephrine right away. We will be risking increasing SVR even further. So this is not the answer. Adding dobutamine by protocol is the key. So I will just walk you through something more. Let us say this patient was added on dobutamine, and after 4 hours, the dobutamine is continuing, for example, at 5 ml per hour. Norepinephrine at good dose, let us say around 10 ml per hour, like 1 microgram per kg per minute dosing. But the BP of the patient still stays around 80/50. What will you do next? Now, what is the diagnosis? Is this cardiogenic shock?
Refractory cardiogenic shock.
So now it is known as refractory cardiogenic shock. So what is the indication now? What you should do? You should add mechanical support. So this was pharma support. Now this is mechanical support. In mechanical support, what are the devices? Number one,
Intra-aortic balloon pump, IABP.
so IABP, very good. Second,
Left ventricular assist device.
so LVAD. So second is LVAD. Supposedly, you put the patient on IABP, the blood pressure still stays around 100. Norepinephrine is going on, dobutamine is going on. The urine output has started around 50-30 ml per hour, but still not very good. Patient continues to be on NIV and the lactates are rising. What will you do next?
We change to VA ECMO.
Yeah, so the next is the VA ECMO. Great. So that is the algorithm that should be followed. Is there any role of hydrocortisone?
Sepsis is no role. But in case of
No.
sepsis, we can think.
Yeah. So as of now, septicemia not mentioned. In case during the course of the trajectory of patient develops sepsis, then maybe you can give them a little bit of hydrocortisone. Or if you can prove that the patient has had a adrenal infarction and has landed up into acute Addisonian crisis, then you can add steroids. What are the features of acute Addisonian crisis?
Severe weakness of the body.
So number one is hypotension.
And severe hypotension and persistent refractory hypotension.
Yeah, it will be persistent refractory hypotension, then persistent refractory hypoglycemia, then persistent refractory hyponatremia, and hyperkalemia. Okay. So if these 4 things are there, like in the question stem, if they say day 5, the patient has decreased urine output. Many times when after putting an IABP, sometimes in short statured people, the lower end of IABP, the balloon, is covering the renal arteries. Sometimes what happens is adrenal arteries are also blocked. So these patients can have acute adrenal suppression. Okay. So you should always keep it in mind that if the patient has developed this, because serum cortisol levels can be done, but they usually are morning samples, they can be done, but also in case you can determine the presence of Addisonian crisis with the help of serum, this There's hypotension, there's serum sodium and serum potassium, and serial ABGs, because acidosis will be there, persistent. And along with that, hyponatremia, hyperkalemia, and hypoglycemia. Okay, so in this particular patient, we will add dobutamine. All right. A 60-year-old post-STEMI patient develops sustained ventricular tachycardia with pulse, but hypotension. What is the best immediate management?
DC cardioversion.
Anybody having a different opinion? So the answer is DC cardioversion. IV magnesium is indicated in torsades, and torsade is typically pulseless polymorphic ventricular tachycardia, in which shock you have to give, but magnesium you give along. IV lidocaine and amiodarone, they are basically meant for hemodynamically stable ventricular tachycardia, and that too amiodarone. Lidocaine no longer is recommended in the AHA protocol, but can be tried and used if the patient has a refractory ventricular tachycardia. A patient in ICU with anterior STEMI suddenly deteriorates. Patient has now bradycardia, hypotension, and wide QRS complexes that have recently developed. Which coronary artery is most likely involved? Very, very nice question. This is an excellent question. If anybody can pick up. So this patient has sudden deterioration, anterior wall STEMI. Patient has bradycardia, hypotension, and new wide QRS complexes. Which coronary artery is most likely involved?
Left anterior descending artery.
Okay, so now you have to tell me why. From which clues in the question have you picked up this answer?
The new wide QRS complex suggests that the patient may have developed left bundle branch block, which might suggest that there is the interventricular septum is involved.
But it could be right bundle branch block also, wide QRS. They have not mentioned anything.
Right bundle branch block.
It could be a right bundle branch block also. Is it possible?
আমি পরীক্ষা দিচ্ছি। এডিক পরীক্ষা দিয়ে তোরা ফোন দিচ্ছি।
Wide QRS
but the fact that
পরীক্ষা দিচ্ছি, এডিক পরীক্ষা দিচ্ছি, পরে ফোন দিচ্ছি।
Now the fact that there is hypotension strongly favors left bundle branch block, unlike right bundle branch block that may not cause significant systemic perturbation.
Okay, so I will help you in this. I will make the things easier for you.
Thank you, sir.
Whenever you read a question, the question has to come from the first word. A patient in the ICU with anterior STEMI. So, number one, the patient has anterior STEMI. So, we cannot undermine the fact that the patient has anterior STEMI. So, anterior STEMI has to be left circulation. Is that clear?
That's right.
And in anterior STEMI, there is a subset of patients in whom there is LAD is involved proximally, and the poor prognostic indicators are onset of bradycardia, hypotension, and wide QRS. You are absolutely correct in saying that the intraventricular septum might be involved, but the defining of the LAD territory requires the understanding that LAD territory, if LAD is obstructed somewhere in the proximal region, it can lead to a ventricular septal infarction. And if septal infarction occur, then this patient can develop even complete heart block, not only the LBBP.
Yes.
They can develop a complete heart block if the LAD is occluded in the proximal region. This has in fact known to be a worst prognostic sign. If patient of anterior wall STEMI lands up with hypotension, bradycardia, and broad QRS complexes, you have to take it that the patient has developed a septal infarction secondary to proximal LAD occlusion. Is that okay?
Yes, sir.
So this patient, rightly you found out that this patient has a LAD territory occlusion. Okay. So now we have another patient, a 55-year-old post MI patient who develops acute limb ischemia with thrombocytopenia. What is the most likely cause? So there was this patient who was admitted in your ICU. The patient was taken up for PTCA. The PCI was done. Eventually, the patient developed gangrene of the leg through which, or the hand through which the procedure was done. So what are the differentials in cases of limb ischemia post PCI?
Heparin induced thrombocytopenia. Heat.
Anything before that? My question was very clear. Differentials of post PCI limb ischemia. My job is not to make you understand these questions. My job is to make you understand the thought behind the question. So you have to tell me what are the differential diagnoses of acute limb ischemia after PCI. Only then we will come to conclusion, not otherwise.
You have a plaque rupture and embolism.
Wonderful. So the most important differential diagnosis is arterial thromboembolism. And from where it can occur?
From the catheter insertion site.
From the catheter insertion site, from aortic plaques, because when you are putting the when you are going with the wire, you go from the aorta, right? This is how you go, right?
Yes.
And yeah. So you can actually, if the plaque is somewhere here, then the wire can go and hit it, and the plaque can dislodge and embolize. So catheter related injury, aortic plaque embolism. Anything else? LV thrombus. Many times these patients who have acute myocardial infarction, they have already developed an LV thrombus at site. So if there is a thrombus inside the left ventricle, it will just pump it out into aorta, and then the destiny will decide where the ischemia occurs. It can have mesenteric ischemia, it can have limb ischemia, it can have renal ischemia, it can have a stroke also. So the number one reason is arterial thromboembolism, which is the most common cause of limb ischemia. Or sometimes if somebody has done a radial cannulation, sometimes if after radial, before radial cannulation, we should always check the collateral circulation of hand. What is that test known as?
The ulnar artery testing, Allen's test.
Allen's test. So if the Allen's test was not done and you put in a sheath in the radial, and then after removing, put in the pressure, the TR band that is there, what will happen is the hand will undergo ischemia. So that can also happen. So this patient can have arterial thrombosis or thromboembolism as the first differential. But we will just gradually walk you through. Number 2 differential is cholesterol embolization syndrome. Nobody spoke it. Cholesterol embolization, very important. There are cholesterol deposits in the aorta and then usually they embolize. It is also known as blue toe syndrome. Blue toe syndrome, very important. Then comes your heparin induced thrombocytopenia, because this patient has a thrombocytopenia and thrombus formation both. So the as such, if I have to go by the data, the heparin induced thrombocytopenia becomes the third option. But because platelet count is known to be decreased, that it favors the diagnosis of heparin induced thrombocytopenia. Other diagnoses here, disseminated intravascular coagulation or antiphospholipid or warfarin induced necrosis, they are not in line with the question statement. So the only answer that we can identify is HIT. If it was arterial thromboembolism, cholesterol embolization, and HIT, the platelet count was not mentioned or was somewhere around 1 lakh, means not clearly heparin induced thrombocytopenia, then the answer should have been arterial thromboembolization. Is that clear?
Yeah.
Yes.
So,
This is how you should.
how does excuse me, sir? How does this heparin-induced thrombocytopenia result in acute limb ischemia? When I thought that with thrombocytopenia, the viscosity of the blood should be low, and we shouldn't expect any thromboembolic events compared to when you have, thrombophilia also.
So basically, your question is ki why heparin-induced thrombocytopenia causes thrombosis instead of bleeding. Is this your question?
Yeah. Why would it cause thrombosis that will give rise to limb ischemia?
So basically, no. Why thrombosis give rise to limb ischemia, or why heparin-induced thrombocytopenia give rise to limb ischemia?
Yeah, that's what I want to understand.
So basically, this is a paradox.
Yeah.
This is a paradox that usually heparin is given for anticoagulation.
Yeah.
And what happens is that there are certain antibodies. So what kind of antibodies? So what happens is that this heparin, it induces the synthesis of certain antibodies which are known as antiplatelet factor 4. Antiplatelet factor 4 antibodies. Now, these antiplatelet factor 4 antibodies, they basically, what they do is they clump up all the platelets. So there is a heparin and PF4 complex. It is then, so heparin platelet factor 4 complex is formed. These red dots are heparin PF4 complex. And when antibodies bind to them, the platelets, they get clamped. And when the platelet gets clamped, this is basically a thrombus. And because this is a consumptive thrombosis, the platelet count actually decreases. There is increase in the platelet clumps, but there is decrease in the free platelets that are counted in the platelet counters. So what will happen is these platelet aggregates, they are moving about in the blood vessels and increasing in size. Why? Because there is antibody attached to the platelet factor 4, which is also attached to the heparin. So heparin will bind to all the platelet factor 4, and platelet factor 4 antibodies will bind to the platelets, increasing the size of the thrombus, and eventually they will plug up a blood vessel, leading to thrombosis. Yeah. So heparin induced thrombocytopenia is basically a thrombus forming state. So it's a procoagulation state. And in this procoagulation state, the thrombi are formed, leading to multiple these occlusions of the arterial blood vessels. Usually, it is the arterial circulation which is blocked and not the venous circulation. But of course, DVT is also known to occur in case of heparin-induced thrombocytopenia. Some people, they give platelet-rich concentrates in such situation that only adds oil to the fire. So there is heparin already in the system. There is heparin-induced PF4 antibodies in the system. And you add more platelets, larger the thrombus will be. So the point I am trying to make is that you have to stop heparin first. You have to give some other anticoagulant which does not behave like heparin. Are you getting my point? Because eventually you need to, even if thrombocytopenia is there, you have to give anticoagulants in this patient, but not heparin for that matter.
Yeah.
Okay. So there are two types of heparin-induced thrombocytopenia. Number one is type 1, which is basically, usually we don't find any antibodies there. It is a self-limiting one. What happens is you give heparin and thrombocytopenia happens, but there is no thrombosis. There is no increased thrombosis risk. It is self-limiting. But it is the type 2 heparin-induced thrombocytopenia, which usually occurs 5 to 10 days after introduction of the heparin, and it increases the incidence of arterial thrombosis, DVT, pulmonary embolism, and everything. So you should immediately stop all heparin, and in fact, you need to start direct thrombin inhibitor. So like ergotroban or bivalirudin, or if you can give oral anticoagulants, then which is the direct thrombin inhibitor oral? It is dabigatran. Okay? Is that clear?
Yeah.
So there are two types of HIT. One is HIT type 1, which is non-immune mediated, very mild, never leads to thrombosis, self-limiting, starts on day 1. The other is HIT 2, which is very, very debilitating, causes DVT, causes thrombosis, causes pulmonary embolism. Usually happens after 7 to 12 days of onset of heparin. So treatment is to stop heparin immediately and start the patient on either bivalirudin or on direct thrombin inhibitors like ergotroban. Shall we move forward?
Yes, sir.
Okay. So a 72-year-old post-STEMI patient develops acute pulmonary edema with a new systolic murmur in the ICU. The blood pressure is 90/60. What is the most likely cause? Very easy question.
B, papillary muscle rupture.
So the most common reason should be
VSD.
Ruptured papillary muscle. If VSD is to be caused, then we have to look that the patient will deteriorate on day 3 or day 5, not immediately. So VSD is a possibility, but in this case, where the patient has developed pulmonary edema, the likely answer strongly should be acute mitral regurgitation secondary to papillary muscle rupture. Okay. As far as ventricular septal rupture is concerned, we will just walk you through the one options. As far as the ventricular septal rupture is concerned, it usually happens 2nd to 7th day, and usually in anterior wall, anterior LAD territory, anterior MI in LAD territory. And there's a loud, harsh, hollow systolic murmur. It's a very loud. So this is a similar differential that we have. And it usually causes biventricular failure. So not only the patient has hypotension, but the patient is cyanosed also because of admixture of the venous and arterial blood. So papillary muscle rupture, it is more likely the reason. This also usually happens on 1st to 7th day. It can happen secondary to anterior, secondary to posterior, secondary to inferior, any kind of MI it can lead to. And then acute severe MR will be resultant. There will be new hollow systolic murmur leading to pulmonary edema. So the confirmation for both of them is bedside echocardiography. A small VSD can be missed, but a large VSD cannot be missed. As far as pericardial effusion is concerned, it takes a lot of time, many days in fact, and there will be, in fact, if there is a murmur, it will be distantly heard. So all the murmurs become faint in pericardial effusion. As far as pulmonary embolism is concerned, it will basically present with pleuritic chest pain, hypoxia, and sudden ECG changes. And on echocardiography, there will be right heart strain pattern. Sometimes in ECG, you can appreciate a right bundle branch block also. So how will you manage a pulmonary edema of acute papillary rupture? So non-invasive ventilation.
Okay,
IV
and
diuretics.
decongestive therapy. Yeah.
IV diuretics, intra-aortic balloon pump. And of course, if you can use dobutamine earlier on, if the patient is not hypotensive. If the patient does not respond to any of this, then what will you do? The patient has to be taken up for emergency mitral valve repair. Okay?
All right.
Then it is a CTVS call. Then it is not a physician's call. All right. A post-STEMI patient in ICU develops fever and pleuritic chest pain on day 3. ECG shows diffuse ST elevations. Now, this is a very easy one.
Yeah.
So, what is the answer?
Acute pericarditis.
So, the answer is acute pericarditis. Correct. 9th, a patient post-STEMI in ICU develops hypotension, tachycardia, and a new harsh systolic murmur at the left sternal border. Now, there is your answer.
Yeah, what is ventricular septal rupture.
Yes, this is VSR. Okay, this is VSR. So it has given in the, they've defined it so well. Harsh systolic murmur at the left sternal border. These are the words that you should look for in the questions. The question statement may be 17 lines long, that a patient came to this. But there will be just one hint that will lead to you to the correct answer. So this is VSR. Question number 10. A 58-year-old post-STEMI patient in ICU has persistent chest pain despite nitrates and morphine. ECG shows dynamic ST changes. What are you going to do next? Very good question.
Perform stress testing.
Repeat coronary angiography.
Patient is post-STEMI. You will not want this patient in chest pain to go for stress testing. It is a big contraindication. A chest pain patient having active chest pain should never be subjected to any stress. The patient may develop a VT and die. So you will take up the patient for coronary angiography. The best step is to take up the patient for, why? Because it could be stent thrombosis. The chest pain is not resolving. The chest pain is not going away. It could be stent thrombosis. You have to take up this patient for coronary angiogram because these patients are on antiplatelets and anticoagulants. Sometimes the stent thrombosis comes and goes. It develops, causes dynamic STT changes, and then goes away. It gets dissolved. But there will be some remnant there. So that indicates that the patient needs to be taken up for coronary angiogram. Yes, a repeat angiogram. Okay. Stress testing is absolutely contraindicated in active ischemia. Okay. A 68-year-old man is admitted to the ICU after a STEMI. He develops sudden hypotension and tachycardia along with clear lung fields. Amazing. The JVP is elevated. So what is the most likely cause? So there is
There is
slight.
right ventricular infarction.
So this patient has developed a right ventricular infarction. And what is the treatment?
It's IV fluids.
Yeah. So we will be increasing the RV filling. So the more RV filling we have, the patient will be better. And we will need to increase the JVP to a level of at least
18 to 20.
18 to 20.
20 centimeters of water.
So why it cannot be left free ventricular wall rupture?
Because the lung fields are clear.
Yeah, so the lung fields are clear, but if the rupture happens, it will cause cardiac tamponade, and RV is the one which gets compressed. Because in tamponade also this will happen. There are chances that in pericardial tamponade, the lung fields will be clear. The JVP will be elevated, but then there is a very important sign in the JVP which will be mentioned in the this thing. That is?
Is it X-ray finding?
The JVP will be elevated and there will be pulsus paradoxus.
Okay.
And
pulsus alternans, perhaps?
Pulsus alternans to begin with is possible, but then if you have to specifically say that the patient has pericardial tamponade, then the patient will have pulsus paradoxus. There will be exaggerated drop in the blood pressure of the patient during inspiration. So the thing is, pulsus alternans can be present in any kind of heart failure. In any kind of heart failure, including restrictive, including constrictive, including all. Why? Because in some beats, the patient is generating good pulse. In some other beat, the pulse is not being generated as good. So that is alternating pulse. Stroke volume keeps on changing in patients of heart failure. Is that okay?
Yeah.
Okay. So the next question, number 12. What we have is a 59-year-old patient post-STEMI develops sustained VT with a pulse. He's hemodynamically unstable. We know the treatment. What is the treatment? No discussion here.
DC cardio version.
DC cardio version. Now coming to next question. A 72-year-old patient with anterior STEMI develops acute pulmonary edema in the ICU with a BP of 90/60, heart rate 120. A new systolic murmur is heard. Again, this is a repetition. What is the answer?
Papillary muscle rupture.
So this is papillary muscle rupture. A 65-year-old post-MI patient in ICU develops bradycardia, 38 beats per minute, and hypotension. ECG shows complete heart block. What will you like to do? What is the diagnosis and what is the treatment?
Transcutaneous pacing.
And the diagnosis is?
Is
diagnosis is
left bundle branch block.
Inferior MI.
No, it is given that the patient has a complete heart block. It is already given. So the answer is there. The diagnosis is given. But what I was trying to know is from you is what kind of complete heart block is this? So this is an ischemic complete heart block. Ischemic CHP. So, first is we should know which coronary event can lead to a complete heart block. It is right coronary artery occlusion. Why? Because in 80% of the population, RCA provides the SA node and the AV node. So when RCA gets occluded pretty much up, like proximal RCA occlusion, there are chances that the patient may develop a complete heart block. The treatment will remain opening up the RCA so that the blood supply to the AV node is initiated again, reperfusion happens. In case still it doesn't lead to any recovery of the complete heart block, including transcutaneous pacing, then you have to do a permanent pacing. So temporary pacing is the initial solution. If it does not recover by 72 hours to 120 hours, so the latest guidelines are about, I guess, 7 to 14 days. But if the patient is on temporary pacemaker, then you have to wait for like what, 3 to 5 days. And if uh, the sinus rhythm doesn't recover, then you have to put the patient on this permanent pacemaker. Is that the other kind of complete heart block is degenerative complete heart block. That can also happen, but in that case, opening of the coronary artery or the coronary artery involvement is not there. So the answer is these patients of complete heart block of degenerative nature need not put on temporary pacing. You can directly take them up for a permanent pacemaker insertion. Is that okay?
Yeah.
Cool. Next question. A 74-year-old man with cardiogenic shock post-STEMI is on norepinephrine. He remains hypotensive with low cardiac output and high SVR. What is the treatment? I don't know why the repetition happens. So what is the answer?
Is to add dobutamine. That was what we...
Yes, so to add dobutamine. Next question is interesting. A patient with cardiogenic shock after MI started on IABP. What is the main hemodynamic benefit of IABP?
Decreases afterload and improves coronary perfusion.
So decreases afterload and improves the coronary perfusion. What is the principle on which IABP works? So what is the principle? The principle is known as principle of counter pulsation.
Yeah.
Principle of counter pulsation. What does this mean? This means when the left ventricle is in systole, the balloon is in diastole. Yeah. And when the left ventricle is in diastole, the balloon is in
systole. It's contracting. It's inflating.
It's contracted. It's deflated. Not inflated, deflated. Okay?
Oh, I see.
Because intra-aortic balloon pump, inflation means diastole. Because what does diastole means? Diastole means increase in the interval diameter. Okay?
Yeah.
Yeah. So the ventricle is in systole and balloon is in diastole. When ventricle is in diastole, then balloon is in systole. Is that clear? That is why it works. This is the aorta. This is the tip of the IABP. This is the LV. Now, when LV contracts, that is systole, it pumps the blood here. And during systole, the balloon remains in diastole. That means it occludes the aorta. So the blood can only reach up to the balloon level. It cannot go beyond because the balloon is inflated ahead of it. So the blood fills up the aorta distends to accommodate that blood. This blood, because it cannot go forward, it rushes into the coronaries because they are present right above the aortic cusps. Because now the aorta is full, no? Blood cannot go anywhere. The blood will have to go into the... Do you need me to draw it again? Have you understood?
Okay.
I'll draw it again. So what's happening is that this is the heart, this is aorta, and here I have put the balloon. Now when the LV contracts, it pushes the blood into aorta. But the blood can go only up to the balloon because now the balloon is inflated, balloon is in diastole. So what will happen is the whole amount of blood that is there, it will distend the aorta. What will happen is aorta will become like this. For that particular beat, the aorta will fill up like a heart. It will become a second heart. Now the coronaries are somewhere here. Now blood cannot go further. Blood cannot go into the aorta because it is occluded. What will happen is blood will go back into the coronaries. That is how coronary perfusion increases with IABP. And then when the LV goes into contraction and then into relaxation, the IABP, it deflates. So when IABP deflates, due to sudden deflation of the IABP, the aorta is full of blood. It will pump the blood into aorta distally. Aorta itself will pump. That is why the SVR will decrease. Because the aorta itself is helping to pump the blood. That means the vascular resistance is lost. So when the vascular resistance decreases, what will happen is the blood will run through the arteries and then try to reach as distally as it can. That is why it decreases SVR, increases cardiac output, increases coronary perfusion. This is all it does.
Yeah.
So have you understood the concept? So
Yeah, thank you, sir.
This is the concept of counter pulsation. Very important. Okay. Next question. Where is it? A 60-year-old post-STEMI patient in ICU develops fever and pleuritic chest pain on day 3 with diffuse ST elevations. Diagnosis is pretty clear. What is the most likely cause? Now the fever has complicated the diagnosis.
We said it's acute pericarditis.
Yeah, so it is acute pericarditis. A 70-year-old patient post-MI develops tachycardia, new heart systolic murmur at left sternal border. The likely cause is?
VSD.
VSD. Okay. Next question. This is also the same repetition. Okay. A 64-year-old post-MI patient develops worsening dyspnea and pink frothy sputum in the ICU. His blood pressure is 85/50 and echo shows an EF of 25%. Out of the options given, what is the most appropriate initial treatment?
Fusimide and inotropes.
Correct. Anything else you would like to add here? Fusimide, inotropes plus?
Beta blocker you also can add.
Beta blockers in acute LVF you
no. Non-invasive ventilation. Sorry.
So you will add non-invasive ventilation and maintain the hemodynamics and eventually try to get the patient on non-invasive ventilation. Is that okay? These were the 20 questions. Now we will go into the neuro part. I hope the cardiology was okay and learning experience.
Yeah, it was excellent. Wonderful
Now
experience.
thank you.